and this will be our third session. And this is on access to evidence-based preventive care services, access to evidence-based preventive care services. I think this session is going to follow nicely on some of the issues that have been conveyed thus far. And I think you're going to see some drilling down on some of the issues as well as some of the different directions that CMMI and others are trying to go on preventive services these days. We're very pleased to welcome our panelists. First is going to be Susanna Bernheim, who is the Chief Medical Officer at CMMI. Then Richard Hughes with Epstein, Becker, and Green, and among other things. I know they're on top of the Braidwood v. Kennedy issue and some related aspects with regard to evidence-based care and policy. And then Bob Smith out of the American Cancer Society. And I'm pretty sure Bob's going to hit on the aspect of evidence-based guidelines and some of the sort of inconsistencies that we're seeing in the field with regard to those. And so, Susanna, if we could go to you first, we're hoping that some of the things that you might hit on are evidence-based prevention. Maybe I think you're very interested in helping providers help patients and beneficiaries be healthier. I know that you care about primary, secondary, and tertiary prevention, and some further aspects about some of the models we heard about, because I know that you're very much tied up on those. So, Susanna, give us your best 8 or 9 minutes. I know you got a lot that you can say.
I was talking to a group yesterday, and I tried to emphasize that I'm going to try to be brief, not quick, because I can have a habit of talking too fast. That's not what you're asking for. I'm going to try to be concise. Thank you, Cliff, and everyone for including me today. I'm really happy to be here. I will do exactly what you said. I'm going to talk a little bit about the uh, overall evidence-based prevention strategy at the Innovation Center and then talk about a couple of our models. For those of you who've been part of the long conversation, I am not going to talk about Wiser, so thank you to Michael, Jeremy, and Hannah for covering Wiser. I'm going to focus on a couple of the other models. As Cliff said, I'm the Chief Medical Officer at the Innovation Center. I'm also adjunct professor at Yale School of Medicine, and I have a family physician. I came in as the chief quality officer, so I think a lot about quality. But when Abe came into the center, he asked me and some of my colleagues, including Jake Quinton, who you'll hear from later today, to really design the evidence-based prevention pillar for the center as part of 3 pillars that he was launching coming into the Innovation Center. And we did this. So I'm going to talk about that pillar and then some models. We did this. We really wanted to think about aspects of prevention that have good evidence for having an impact on patient outcomes, but where we are not great as a health system at moving them forward. So there have maybe gotten less attention, or we don't know how best to design payment models to encourage them. And so, in the history of the Innovation Center, primary care has gotten and continues to get attention, and there's a lot of really important preventive activities that happen in primary care, measures that incentivize that. Those remain important. But this was trying to build tests in the Innovation Center that help us understand how to embed more of a focus on lifestyle, and particularly nutrition and physical activity in payment models. And again, it's not that we don't know that nutrition and physical activity make a big difference for both primary prevention, secondary prevention, and tertiary prevention, but we don't necessarily do a great job. And so what I'm hoping the new models will do is help us to develop evidence about how to implement changes in care delivery and in payment to encourage and support nutrition and physical activity. And again, not limited to those, but with a real focus there. And as has come up in Abe's talk and earlier today, what's special about the Innovation Center is that we have a range of levers, flexibilities, payment incentives, measure incentives that we can employ to design a model to try to bring about change and to understand what needs to change. And if our tests are successful, success means either they lower costs and maintain quality, or they improve quality and maintain costs, or best of all, both improve costs and improve quality. We can then expand them nationally. So I'm just going to talk a little bit about the levers we're thinking about employing, and then I'll show how they show up in a couple of the models. And again, trying to talk slowly, but be concise so we have time to hear from everybody. I think this is going to be a really interesting panel because we're bringing very different lenses to this issue, and they're all really important. So I'm excited to hear from my colleagues. So a couple of levers we think about. One obvious feature of value-based payment models is measurement. So we took a look at our measurement, and again, we have measured some key aspect of prevention. Robert may talk a little bit about how we could do better on some of those, but they've been in our models before. But there's a lot of ways in which preventive care has a long tail in terms of its impact, and we wanted to see whether we could take another look at what we measure to really incentivize primary prevention. How do we look at whether we are reducing the risk of developing a disease at all? Tertiary prevention, how do we understand whether we are impacting the trajectory of a disease? So in our kidney care choices model, we're looking, for instance, at slowing the progression of kidney disease. Access is really a good example, the access model, which I'll talk about later, around reducing risk. So we can't show that there's the absence of disease, but we can show that we're reducing the risk. That's a shorter term outcome. That's really the benefit of our prevention. We're thinking about folks being at home. We're thinking about avoiding unnecessary utilization. And finally, we're taking another look at whether we can do a better job of measuring things like functional status and well-being as outcomes of our prevention activities. So that's one lever. How do we use performance measures to drive prevention in our models? Another tool that is somewhat unique to the Innovation Center is beneficiary engagement. We have the ability to allow providers in some contexts to offer incentives directly to beneficiaries. So in the ACO REACH model, there is the ability to reward patients for engaging in chronic disease management. And because it is not easy to support folks in things like behavior change, which is really what we're talking about in this case, we've been trying to think about how we build models that create flexibility for providers to try new things, hold providers accountable through our quality measures, and give them the ability to help patients and encourage patients through these beneficiary incentives. So it's a array of levers that can help us to try and drive prevention. A couple of last notes. We're really interested in supporting providers with their work with community-based organizations that supplement care through evidence-based prevention. Some folks are doing amazing work in their own clinics with multidisciplinary teams, but we saw, for instance, in ACO REACH, a real increase in the number of ACOs that had formal partnerships with community-based providers. This can look like a evidence-based program to support fall prevention, or it can look like a connection with the Medicare Diabetes Prevention Project. Lifestyle changes that keep folks healthier that are outside of the clinic walls. And then finally, and obviously, we're exploring the role of technology in creating more access to these kinds of things for patients. One aspect in last year's physician fee schedule was that we are formally testing asynchronous access to the Medicare Diabetes Prevention program, which allows for folks not having to go into a brick and mortar, but to have access to that really rigorous and scientific program that helps folks with prediabetes. Again, I'm going to talk about access, which is the other obvious example of that, but I'll talk about that in 1 minute. I will say that a lot of prevention work sits in primary care. And although we don't have as many typical standalone primary care models in the center, the AHEAD model, which is a state-based model, the Shared Savings Program in the Center for Medicare, and ACO REACH with its successor LEAD are really, these ACO programs really serve as the hub for some of the primary care work. Okay, I'm going to take 2 minutes to talk about specific models so you can see how some of this plays out. Access has come up before today, so I'm not going to spend a lot of time, but here's the fundamentals. It is really a test of whether we can use outcome-aligned payment in original Medicare to expand access to technology-supported options for our beneficiaries to improve their health. There are 4 tracks focused on early cardio-kidney metabolic conditions, folks who have, say, prediabetes or have hypertension without a lot of other risks. There's a cardio-kidney metabolic condition track. That's for folks who are a little further along in their risk for these diseases. There's a musculoskeletal condition track and a behavioral health. The early cardio-kidney metabolic is particularly relevant for our prevention work. And here we're paying for clinically meaningful improvement in weight, lipids, blood pressure, and A1C. And in its best incarnation, this is basically a supplement to me in my clinic for somebody who needs more continuous engagement around these diseases. And requires that information comes back to me as a primary care doc. I have a small payment for looking at that information and using it in my care. So if we're successful, it's really going to be integrated with primary care. But, relevant to the prior discussion with Mike, we're learning, and this is a test. And an important feature of the access model is that it is a randomized control trial. A small percentage of people will be randomized out of this model so that we can really figure out what's working or not.
Did not know it was an RCT. Thank you for that.
Absolutely. Okay. Maha Elevate is a totally different approach. Here, we're saying we know there's things that work out there. We know providers are doing things that Medicare's not paying for. We don't know what the best one of those is to build a big model around. So we are trying to learn about things that we don't currently cover in Medicare that drive better health and lower costs. The model's going to provide approximately $100 million to fund 30, up to 33-year cooperative agreements. So these are smaller proposals. 3 years is not a lot of time. We're looking for practices that have experience in delivering an intervention that Medicare doesn't currently cover that drives better health outcomes. We want to focus on physical activity and nutrition, but not exclusively on that. And we want to make sure we're partnering with folks who can have evidence that they can give us real data about cost and outcomes. But there's going to be a lot of variation among these providers. This is a way for us to say, what should we be testing? What should we be scaling? It's really an opportunity to learn from evidence-based practices that are not yet paid for by Medicare. And then last, I'll say both Access and Maha Elevate are sort of looking at particular interventions, but part of the conversation previously was about the importance of some of these tests sitting in broader total cost of care structures. And so LEAD has been announced, more information coming. It is the new ACO model from the Innovation Center. And it is a 10-year model, so it's got a long runway. It's got more stable benchmarks. It's meant to help bring in different kinds of providers. And then when it comes to prevention, there are a number of those levers I talked about before that are all going to be built into LEAD, right? So we're looking for ways to create flexibility for providers to test new preventive interventions. We want to hold them accountable for doing those tests and helping us see what works. We've given them some flexibility around engaging beneficiaries, both with something like a reward, as well as an expansion of the ability to use medical nutritional therapy in their models. And we are trying to support them in connecting with community-based providers as they do more preventive activity. So that's a place where we're sort of trying a bunch of different levers to see how we can build payment systems that better support preventive care, particularly around lifestyle. And I'm going to stop there.
Great, thank you. Just before we move on, Susanna, with regard to, I guess, Elevate and nutrition, physical activity, is Elevate going to help us learn what sorts of nutritional and physical activity practices improve healthcare outcomes and or how we change behavior to do what we know is the right thing in nutrition and physical activity outcomes?
What I hope it's going to teach us is how should Medicare pay for and encourage interventions in the clinical world that do all of those things. So I don't think we're going to answer the question of, people should run 30 minutes or walk 40
Right.
minutes, right? We're not trying to do that, nor are we trying to answer the question of, um, uh, I forgot what your second version was, but really we're trying to say,
Behavior change, yeah.
right, we're like it's related to behavior change, but it's really sort of how do payment and care models
Ah,
help drive,
right.
give, help providers help their beneficiaries? Because that's really our job, right?
That's what we're going to learn is how do we pay and set up incentives to get them to do the right thing, right? What payment incentives and models work?
That's
Thank
the
you.
hope. You're welcome.
Excellent. Oh, this is great. Thank you. Well, Richard, I'm hoping you can hit on Braidwood v. Kennedy, um, and perhaps the misinformation, disinformation stuff going on out there, which I know is in the ether everywhere, and then maybe uh, what we're seeing so far as fragmentation and standards of care and guidelines, because
Yeah.
that'll be a nice lead into what Bob I know is going to want to talk about.
Yeah.
Richard, you're on.
Yeah, thank you so much, Cliff. And what a great panel. I'm so excited to be here. Just love the diversity of the viewpoints and perspectives. So just to get to Braidwood and to get to some of those questions, I'll take a step back for a moment and talk about the legal and the policy architecture of prevention and some of the challenges that we're seeing. And so What I really mean by the legal and the policy architecture is we worked really hard, really incrementally for a long time to build into federal law and in a lot of state laws, but into federal law, a system where we translate evidence into recommendations and then in turn into coverage and access for patients, right? And really, the exemplar of that is the commercial insurance coverage requirement that lives in Section 2713 of the Public Health Service Act, which is the ACA's preventive services coverage requirement. I tell my students every semester it's the most significant piece of insurance law ever in the history of the United States. It's not an overstatement. It's a very, very substantive piece of insurance law. It is a benefit guarantee that requires payers to cover really substantive benefits. And so we don't have that in Medicaid. Unfortunately, the way that we've approached that coverage in Medicaid is just really, really fragmented and really, really poor. We back in 1967, we realized that we needed to add the EPSDT benefit. We've added some incentives here and there for states to cover certain preventive services, but we really, outside of Medicaid expansion, have not provided have not created requirements for optimal coverage of preventive care in Medicaid. Same thing in Medicare. So if you look at the Part B statute, Section 1861 of the Social Security Act, Congress has gone in and sort of put in very specific requirements for certain screenings. It's really ossified. I don't think that it's ideal for Congress to be trying to make evidence-based recommendations or deciding coverage. We need laws that are dynamic and really reflect evolving standards of care. And we just don't have that in Medicare, like we do, again, with this exemplar in 2713. Um, I would one day like to see us apply 2713, broadly across all sources of health coverage in this country. But before we can do that, we've got to take a step back because we have some serious challenges right now to this model. And it's really what I've seen is very concerning for the future of expert recommended evidence-based preventive care. This really is kind of coming in two forms. One is from within the judiciary itself, where you have a concerning environment for expertise, but also with the current administration and some of the misinformation around science and particularly around vaccines and the recommending bodies. And I'll elaborate on that a little more in just a second. But I'll say that a couple of years ago, as we all know, we saw the overturning of Chevron. And of course, everybody asked, what does that mean for preventive care? If you take something like Section 2713, it's pretty clear what these bodies are supposed to do. You don't really have a Chevron Loper-Bright problem. That problem more arises when it's unclear what the agency's been asked to do. But we saw a very specific challenge in that vein of administrative law in Braidwood v. Kennedy. And for those who followed it, it was at one point Braidwood v. Becerra, but ultimately Braidwood v. Kennedy was the final caption in the case. This was the most significant challenge to date that we've seen to the ACA's preventive services coverage requirement. We saw those contraceptive mandate challenges a few years before, but Braidwood really squarely took on the entirety of the preventive services coverage requirement because the plaintiffs had religious objections. They brought Religious Freedom Restoration Act claims, but put that aside. What was really concerning here were these arguments that this structure, giving the recommending bodies the authority to determine insurance coverage requirements under the ACA, they said that violated the Appointments Clause of the U.S. Constitution because they were wielding really significant authority. It's just generally, constitutionally speaking, there's this principle that you want to delegate responsibly. Congress can't over delegate its powers, and this is just sort of one flavor of that sort of concept. And the lower court judge looked at the differences between ACIP, the U.S. Preventive Services Task Force, HRSA, and the way their roles are set up under the ACA. So, there's not really an issue with ACIP because they're politically accountable because the CDC director reviews their recommendations. HRSA is an agency where there's some built-in accountability up the chain. They said, the task force is independent and they're operating pretty independently, and maybe there's not sufficient political accountability. We were very concerned because there's literally language that politically insulates the task force in federal law. And so we were concerned about where the Supreme Court was going to go. The government maintained the same position in the case as the Biden administration transitioned over to the second Trump administration. And I, representing a couple dozen Amici and a lot of others in this community, we said, we're going to have to support the government's position in this case that the secretary has the ability to remove members of the task force. The secretary has the ability to decide whether to adopt or reject recommendations of these bodies, because that's what it's going to take to help these bodies survive. If we want this framework to live on and to have
Mhm.
evidence-based coverage requirements, we have to say that the secretary has final say. There has to be political accountability. That was an uncomfortable position to take for obvious reasons. And as last year progressed, we had the decision in June, but that's happening against the backdrop of the secretary undermining preventive, these recommending bodies. And I'll talk in a minute about my lawsuit against the secretary. Um, but ultimately, we came out in with what I've called a double-edged sword. The Supreme Court said, yes, the secretary can remove members of the task force. Yes, the secretary can reject or adopt its recommendations, and that is sufficient political accountability. The task force, the ACA requirement lives on. That was great. But of course, there's the fact that it affirms the secretary's ability to decide whether to accept these evidence-based recommendations. And so, I will just say before I move on from that the difference is it sounds like a lot of legal jargon. It sounds like we're, being overly legalistic about, just a few bodies that are making evidence-based recommendations and does this really matter? It really does matter. The differences in how these bodies work. So the fact that the ACIP, does its recommendations one way, the task force does it a different way, that HRSA actually relies on professional societies in making its recommendations. Those processes are all very, very different. And you can see when you look at cases like Braidwood, if you look at AAP versus Kennedy, which I'll touch on, those differences matter legally, and it's going to ultimately impact whether these requirements survive. Also say, as I mentioned, the degree of delegation matters. If you over outsource, you might get checked in the courts. Okay, so I just want to come to what's going on with these recommending bodies in this administration. We saw the secretary last year promise to Senator Cassidy that he was going to maintain the ACIP without changes. Immediately broke that promise. The committee's been reconstituted. It's comprised of vaccine skeptics and anti-vaxxers, unfortunately. It's become a platform for misinformation, for junk science, deeply concerning. He's gone around the committee to make his own policies, announcing COVID policy changes, announcing a whole new immunization schedule on January 5th, and he's not following process. That's illegal. So the secretary has a lot of authority, and he can do these things, but that is subject to the Administrative Procedure Act. The Administrative Procedure Act says that an agency cannot act arbitrarily and capriciously. That means you've got to take a good hard look at the science. You got to explain your rationale and your reasoning. You've got to go through a process. And when you look at the traditional processes that these bodies have gone through, we're basically saying to the court in our lawsuit that those processes have to be respected. They can't just be discarded overnight. You can't do things based on a whim. It's been really unfortunate personally to sit in the courtroom and listen to the government argue that these are differences of opinion, that we all have
Mhm.
the same goals to protect public health. It's just not true. And so hopefully we prevail in this case. Cliff, did you want to?
Yeah, so just and I
Mhm.
just you have just
Yeah,
another minute or so.
yeah,
Bottom line, Richard, where do you
yeah,
think this leaves us with
yeah,
regard to making evidence-based
yeah,
clinical and policy decisions? Where stand we
yeah,
now in the
yeah,
sort of infrastructure to do this?
yeah.
Briefly.
Yeah, so the professional societies are absolutely stepping up, and it's great to see. And that is legally sound. Professional societies are the way the law is always recognized. The professional societies set the standard of care. We should lean on the professional societies. We should support the professional societies in their work, but we've got to think about the future. So for all of the reasons that I've said, we've got to start to think about how policy for preventive care should work in this country. We got to think about the timeline that we have to make those changes and what it should look like.
Excellent. Thank you. Thank you very much for putting those views on the table.
Yeah.
I must add to the crowd that's on this call, ACA 2713 was how shall I say, the creation of the VBID Center largely. And the VBID Center had a lot to do with putting the ideas together, working on the language and making sure it's pushed through. And so the crowd in this call is very much aware of the importance of ACA 2713. And again, we appreciate you laying these issues on the table. Thank you very much, Richard.
Of course.
Bob Smith, this is a great handoff to you because Richard just finished up talking about the professional societies and where we stand and who's responsible for what with regard to the evidence base itself and converting that evidence and interpreting it into recommendations and related policies. Bob, what do you have for us?
So I'm very happy to be here, and I've enjoyed this discussion very much, especially this most recent one, which is most relevant to what I'm going to be speaking about. Um, when we look at the importance of cancer screening, it has to be in the context of the overall burden of cancer. One of the interesting things that's happening right now is we're having discussions about what we've accomplished with the cancers that we screen for, the five: breast, cervix, colorectal, prostate, and lung, and then the remaining burden of disease that might be addressed with these new molecular tests, in particular the multi-cancer early detection tests. One of the things that I think is very important to stress is that there are a lot of factors go into whether you avoid a premature death or not. But cancer accounts for the majority of premature deaths in this country. It's the leading cause of premature death. And in fact, the five cancers we're talking about account for about half of years of preventive life loss. And it's about 10 million years a year. It's substantial. And so when you think about all that we can accomplish with early detection and all that we don't accomplish with early detection, it leads you to sort of start to wonder, how might we do much better, with much more of a system. So, I have everybody here has said I could go on for days, with everything that's going on here. But we want to say, on the one hand, we've really accomplished a lot. I mean, we have reduced deaths since 1991 by a 1.5% per year, roughly 4.8 million deaths prevented as a result of progress in early detection. A lot of smoking cessation and not uptake of smoking, but also improvements in therapy. But it still leaves a lot of room for improvement on the table. And so when I think about the challenges in screening, I mean, let me just go through a quick list. I mean, our evidence generation takes too long. If you look at how long it took for us to just more recently get to a recommendation for lung cancer screening, it was close to 15 years. And then there was a lag in insurance coverage, as under the Affordable Care Act, that's required there. And all during this period, no planning for implementation at all. No thinking about what it's going to take or preparing the public or the clinical community for the challenges that they're going to meet.
Bob, let me just for a second. I don't want to lose the point. Three related things you said. We're not doing so well in evidence generation because it takes too long. It takes even longer and more fragmented for insurance coverage. And then we're not so great at implementing. So all three of those things are on the critical path to better screening and prevention.
Yeah, absolutely.
Yep.
It's remarkable, really, if you think about it. One of the things that is certainly vexing to clinicians is that guidelines are out of sync, commonly out of sync, and they're out of sync because of different cultures and different approaches to guideline development. They're also out of sync just because they update at different times, and evidence is different when they update. It might seem that we don't talk to each other. Right? We actually retain a very cordial relationship with the Preventive Services Task Force. In many ways, you could say that the ACS and the task force and the NCCN are the big dogs in this field. But it would be nice if we could all get together, and there's reasons that we can't. It's quite understandable. We estimate screening rates from self-reports, and they are nowhere near as high as the ERFS or the NHIS estimates that they are. And they are measuring the most recent screening event, not adherence to routine screening. And frankly, our data shows very, very clearly screening works best when it's done regularly. It's not a big deal if you don't have cancer, but if you miss screening tests when you do, the consequences can be tragic. Most individuals do not get on-time regular screening. Most individuals don't understand everything they need to know about screening. To me, one of the most surprising things that we learned recently is how many people who are eligible for lung cancer screening don't consider it because they think they can't afford it. and they have no awareness that it would be covered at no cost under the Affordable Care Act or by Medicare. This is much worse for marginal populations. That's a clear thing we understand. And there are access issues both as a result of low insurance, low income, and geography. So we face enormous challenges. And one of the ones I am going to talk about a little bit more is the out-of-pocket costs. And what we've managed to see recently is under the Affordable Care Act, we have this definition of screening versus diagnostic that really complicates coverage and reimbursement. We have always maintained that screening should not be thought of as a discrete series of events. You have a screening event, and then depending upon the results, then you have a series of diagnostic events. In fact, that screening event is not worth much of anything if it's positive and the patient is not followed up. Screening is better really thought of as a continuum of information gathering in which we are attempting to answer a fundamental question that led the patient to get screening in the first place. Do I or do I not have cancer? And so if you think of it as this discrete thing, and actually with right and wrong answers, you sort of create a false sense of what's really required to have a successful screening event. Even the fact that a patient can be recalled and that whether or not they have or do not have cancer is defined as a true or false positive, when in fact the radiologist or the gastroenterologist or anybody who recalls the patient, screening tests are not diagnostic tests. You have a level of suspicion. You cannot return that patient to the normal screening pool until you get more information. Technically, recalling them was the correct call. The positivity was correct inherently, even though it ultimately doesn't tend out to be. So we've been pushing this idea because it seemed to really influence the degree to which, very much influence the degree to which under the Affordable Care Act, patients would have their test covered at no cost. But if they had a positive test result, if they were defined at elevated risk, they would start facing out-of-pocket costs and co-pays that might never, ever return to the average risk status. In other words, a person could be in this co-pay purgatory for the rest of the years that they get screening. And it certainly is the case that the charges could be quite uneven across the board for patients that need these additional tests. And sometimes they need a great deal of additional tests and more frequent tests. And all of a sudden, they end up spending quite a few out-of-pocket costs. And in fact, it could be actually, for some of these diagnostic investigations, can be quite expensive. So we stressed this point in 2018 in a series of papers we wrote on blueprints for cancer control, and the one on screenings emphasized this continuum of information gathering, and in fact, that too many people, and it's actually substantial numbers of people, as many as half for a positive colorectal cancer screening test. Today, as many as 4 out of 5 people who've undergone lung cancer screening and have been recalled or not getting follow-up imaging, that things are getting in the way. And it's not just copays, it's geography, it's lack of medical literacy, it's the lack of nobody's really in charge of making it happen, and that it is something that undermines all the work that has been done in front to get the patient into screening. So we wrote this in 2018. In our 2018 colorectal cancer screening guideline update, we stressed this point again, that a positive colorectal cancer screening test, a non-colonoscopy screening test, without a follow-up colonoscopy is not complete. And in fact, it does not lead to answering the fundamental question as to whether that positive test was cancer or not. This is not trivial, frankly, because in a really failure analysis that was done at Kaiser, they showed that failure to follow up a positive colorectal cancer screening test led to a 7-fold odds of death from cancer compared to people who were adherent with their cancer screening.
I've heard you use the phrase living guidelines. Can you give us, 30 seconds on what you mean by living guidelines and why we need to move in that direction now?
Yeah, so going back to what I mentioned earlier, I mean, a very good example of this is when the task force updated their colorectal cancer screening guidelines in 2016. They kept the starting age at 50. By 2017, our colleagues at ACS had demonstrated that rising incidence in colorectal cancer was a birth cohort effect, and that rising incidence was migrating into the adult ages when you begin screening, moving through the 40s and into the 50s. And in fact, at 45, the incidence of colorectal cancer was at the rate it was in the mid 1990s when we established 50 as a starting point. Our guidelines are out of sync. They're 5 and 6 and 7 years apart from being updated. And so that was one among several examples that led us to decide that we were going to shelve our methodology of periodic updates and replace it with a living guideline model where you don't tear down the whole guideline and build it from scratch and reissue it, which is a common part of that methodology is to revisit the old data. But in effect, you update the guideline according to whatever the new evidence warrants for a guideline update. That
So,
means that guidelines could be updated in as little as a year.
so that would get at your kind of evidence generation problem out front, keep things moving faster. We want to make sure the insurers kind of stick with that. One thing, Bob, you talked about the cancer screening purgatory and the out-of-pocket cost problem and so forth. Are we ginning up any policies or any kind of advances to address that?
We are. And what happened was in 2018, when we issued this strongly worded,
Right.
description of the continuum of cancer screening, in 2020, we reviewed the task force's draft guidelines and implored them to include this in their update, that screening was not a discrete act. There was a continuum of information gathering, that the test was not complete if it was positive and there wasn't a colonoscopy, and they did. And
Hmm.
when the
Hmm.
tri-agencies looked at that and looked at the comments that they had received in the update, they decided that if it is part of screening, then it has to be covered. And they issued their first new coverage decision in the FAQs that a follow-up colonoscopy after a positive non-colonoscopy test had to be covered without
Yes.
any out-of-patient costs. That has also led to coverage that has been decided. That was as of 2023. Breast cancer now is following that. Follow-up after an abnormal mammogram has to be covered, whether that's ultrasound, MRI, or biopsy. For cervical cancer in 2027, follow-up tests will be covered. Both breast and cervix follow-up actually includes navigation now. So
Yes.
we're making real progress here, but unfortunately, lung cancer is not yet added to that list.
That would
And
be low dose lung CT.
yeah, that would be low dose. It would be, yeah, you could actually do the follow-up with a low dose
You do.
CT.
So, question for Susanna then. Susanna, you've talked with it, whether it's Reach or Access or others, you're trying to incentivize providers to do the right thing. Do you foresee gaining findings or insights from those models, those incentivizing models, to bridge the kind of gap we've just heard about from both Richard and Robert, insofar as kind of providing a better way to at least implement evidence-based care? Because I want to see, like, you seem to be doing some pretty cool things to kind of get people to do the right thing through these incentives, but Bob ain't feeling it yet. And I'm just wondering if you have any kind of reflections on that.
I mean, I hope so is the main thing, right? I mean, that's certainly why we're here, is to sort of try to figure out how you build a set of incentives and flexibilities and encouragement. The prevention pillar right now is focusing so much on sort of nutrition and lifestyle, but there certainly are examples in the center's history where we have done something that's at least adjacent to what you're talking about. It wasn't about cancer screening, but the Million Hearts model was an example where we paid for comprehensive screening for cardiac risk and an additional payment for addressing risk in certain patients. And that was a very successful model. And the Center for Medicare then changed payment to build on that, to have an add-on to encourage that same comprehensive screening by paying physicians more if they did it because the model worked. So it's one example, and again, Jake Quinton, who's on your next panel talking about something different, was really at the center of making that translation from our model to the payment change in the Center for Medicare. But yes, I mean, if our models work, sometimes they're scaled, and sometimes they just teach us how to change our payment systems, and we can do that
Mm.
as well.
Well, I think we're hoping that some of the things we can learn from your work can translate into kind of incentivizing the kind of behaviors we're looking for in prevention. Just by the way, another question that came in was, and this is would be to you, I think, Suzanne, and that is, what about low value services? You've talked about incentivizing doing certain things, but for example, I know that this group has talked about, and Low Value Care Task Force has talked about things like routine vitamin D testing and other low value services. Are you kind of working in that direction as well, that general direction?
Yeah, I mean, I'll say a couple of examples of where that's a focus. I mean, obviously, the wiser model itself is really about low value services, right? These are things where there's been a coverage decision that there are certain circumstances under which a particular procedure doesn't make sense, but we don't always enforce those. And with prior auth, we're hoping to do that upfront, rapid, reminder, if you will, that we don't think in this clinical scenario there's evidence that this would be high value. So that's the classic sort of approach to low value that's a new test.
Mm,
We are, the hope in general of total cost of care models is that as providers are trying to reduce costs, they are going to look for places to weed out low value care. Is that always the way these play out? Maybe not, but that's certainly it. And then in the specific case of the MAHA Elevate model,
yeah.
because there's a wide range of things that folks are interested in Medicare covering, we have pretty strict requirement that there be some evidence that the intervention works. We're not willing to sort of test things that don't have decent evidence. The real goal is to figure out if there's things that have some evidence that can be applied to the Medicare population where we don't currently cover that intervention. But there's going to be a pretty strong filter related to the evidence for that MAHA Elevate. Again, it's not exactly about low value care, but it is about, not paying for things that we don't know work.
So Elevate does have an evidence bar, as it were. We're looking
Exactly.
for something there.
Exactly.
Thank you. Bob, our buddy Jeff Levin Shirts came in the comments with regard to colorectal cancer. He makes this point, I think you might have been partially alluding to it, with regard to once you've had a screening colonoscopy and you've got a history of polyps or even cancers, every subsequent colonoscopy continues to be treated as diagnostic, and that therefore requires cost sharing. So this whole issue sounds pursuant to the point you were making about a continuum as opposed to discrete, isolated screenings and other interventions. We're looking for a continuum here that's supported by payment. Comment, Bob?
Well, I think it has to be seen as a continuum. The patient is at higher risk and they need specialized care. Our argument would be that that should be woven into the insurance coverage and spread across the population, but
Yeah.
not end up being a barrier to the patient's care. We all read of these tragic accounts where people don't get the care they need because they just can't afford it. So let me
Hmm.
mention this one other thing because I think it's critical in this
Sure.
continuum we've been talking about is that HEDIS has just announced that they're going to pursue a measure that basically attaches the follow-up care after a positive colorectal cancer screening test to the completion of the screening. So essentially that screening does not count to the HEDIS measure unless the patient has actually completed it through the follow-up colonoscopy. Now, in the context of what gets measured gets done, it's one thing to make sure that the coverage is there, but we know that there are many more barriers that patients face, even if they're not even unaware about the coverage issues. And many of these patients need navigation or the support of their provider to get through that. So essentially,
Yeah.
the NCQA would be sending a signal to the plans that that screening test you're counting that didn't get followed up can't count unless the patient gets followed up.
Point
This
well
should be
made.
in
Yeah.
place for every one of the screening HEDIS measures going forward, and I would hope that it could be in place very, very quickly. I would say, however, that this kind of carrot and stick approach,
Hmm.
that's sort of almost voluntary, is a poor substitute for a system that other countries all over the world have that
Yeah.
ensure that patients get reminded for screening on time, they get followed up if they need to have the follow-up care, and we could accomplish a lot more from screening if we had a system like that.
Yeah, that would be a big win. Richard, in under a minute, what does a mended system look like? Because I think you've suggested there's some breakage here and some fragmentation.
Yeah.
You've also heard Bob talk about, you've talked about how the professional societies are trying to fill in some of the gaps and so forth.
Yeah.
A mended system would look like what?
Well, we've got to address that issue of market fragmentation, those differences across markets. I think we need to go in and do surgery on the Social Security Act to get, the same kind of adequate coverage that we have in the commercial market, although the commercial market needs some tweaks too. And I think that we may need to consider shifting toward a system where everything is based on professional society guidelines. That has to be written into the law really, really carefully.
Mm,
But that may be the most reliable approach. And I've said this very openly to AHIP. I think payers should just cover preventive care. If the provider says this is preventive care and I'm following guidelines and I'm doing this with my patient, let's just cover it with zero out of pocket. And we're at that point as a society that we should just accept that. I realize that is a crazy idea to some people, but we really should consider moving in that direction.
thank you. Some people thought 2713 was crazy, but maybe not
Yeah.
so. Maybe we can
Yep.
build on that. Well,
Exactly.
thank you. When it comes to access to evidence-based preventive care services, I hope you'll agree that hearing from Susanna Bernheim, Richard Hughes, and Bob Smith couldn't have done better. We've learned a lot, very much like the way your issues sort of flow together and or sometimes bump up against each other. But this has been a very revealing discussion. We really appreciate the time of all three of you, and please do all three of you continue to take the leadership in your respective roles. We will all benefit. Thank you all.